If you're over 40, some of the exercises you're doing right now are working against your body in ways that won't show up until serious damage is already done. I'm talking about accelerated joint degeneration, hormonal disruption, spinal injury, and long-term loss of function. And the painful irony? Most of these are exercises you've been reassured are good for you. As a physician, I think you deserve the full clinical picture before your next workout. Let me be very clear before we go any further. I am not here to tell you to stop moving. Physical activity is, without question, one of the most powerful medicines we have. But medicine is dose-dependent. What is therapeutic in one context can be harmful in another. After 40, your physiology has genuinely changed, not declined, changed. And training that ignores those changes isn't dedication. It's a clinical mismatch. Your cartilage volume is reduced. Tendon elasticity decreases. Hormonal profiles shift in both men and women. Your nervous system's recovery window lengthens. Ignoring these changes in pursuit of the same workouts you did at 25 doesn't make you disciplined. It makes you a patient waiting to happen. So let's talk about what the evidence actually says. Exercise 1 to reconsider: high-volume distance running on hard surfaces. I understand why this one is going to be difficult to hear. Running has been positioned as the gold standard of cardiovascular health for over half a century. It's accessible, it's free, and it carries a powerful identity for many people. But let me walk you through what is biologically occurring with every stride. Each foot strike on pavement generates ground reaction forces of approximately 2.5 to 3 times your body weight, traveling directly through your knees and hips. For a 180-pound individual, that's roughly 450 to 540 pounds of compressive force per step. A typical 3-mile run produces around 4,500 of those impacts. Do that 3 to 4 times per week, and you are accumulating millions of high-load cycles on joint structures that after 40 have meaningfully less capacity to absorb and repair from that stress. The synovial fluid that lubricates your joints decreases in production with age. Articular cartilage, which has no direct blood supply and therefore very limited regenerative capacity, thins progressively, and your inflammatory response, your body's repair system, becomes more reactive and less efficient. The result is that microdamage accumulates faster than it heals. There's a study I find clinically important here, the Copenhagen City Heart Study, which tracked runners over 12 years. The findings were striking. Light joggers running easily 2 to 3 times per week showed the best longevity outcomes. Strenuous joggers, those running hard more than 4 hours weekly, had mortality rates statistically indistinguishable from sedentary individuals. Let that sink in. Aggressive running produced the same mortality profile as not exercising at all. The mechanism is cortisol. Chronic high-intensity aerobic exercise produces sustained elevations in cortisol, your primary stress hormone. After 40, chronically elevated cortisol is physiologically destructive. It is catabolic to muscle tissue. It preferentially deposits visceral adipose tissue, the metabolically active fat surrounding your organs, which itself drives systemic inflammation. It suppresses testosterone in both sexes. It disrupts sleep architecture, and it sustains the low-grade inflammatory state that underlies cardiovascular disease, type 2 diabetes, neurodegeneration, and certain cancers. And muscle loss, sarcopenia, deserves particular attention. It is one of the strongest independent predictors of early mortality in the medical literature. It is directly associated with falls, functional decline, hospitalization, and death. When you are chronically overrunning, you may literally be using muscle protein as fuel, accelerating the exact process that shortens lives. My clinical recommendation: if running brings you genuine joy, keep it, but with modifications. 2 easy runs per week on soft surfaces like grass or trail at a true conversational pace. This is zone 2 intensity. You can speak in full sentences without gasping. For your remaining cardiovascular sessions, transition to low-impact modalities: brisk walking, cycling, rowing, swimming. You preserve cardiopulmonary benefit while protecting the joints you will need for the next 4 decades. Exercise 2 to reconsider: treadmill walking while gripping the handrails. This one may seem minor. It is not. When you grip a treadmill's handrails, even lightly, you fundamentally alter the biomechanics of gait in ways that produce downstream musculoskeletal consequences. Here is what is happening mechanically. The handrails allow your upper extremities to bear a portion of your body weight, reducing the actual load through your lower limbs. The belt moves beneath you, meaning you are reacting to the belt's motion rather than actively propelling yourself forward. And critically, your shoulders are fixed forward and your pelvis tilts posteriorly. In this position, your gluteal muscles, arguably the most important muscle group for lumbar spinal stability after 40, simply do not fire. Normal overground walking is a glute-driven movement. Heel strike, glute activation, hip extension, propulsion forward. That is the intended neuromuscular pattern. Treadmill walking with handrail support breaks that pattern at every step. Gait analysis studies have confirmed measurable differences between treadmill and overground walking, reduced stride length, decreased hip extension, and significantly diminished gluteal activation. Repeat that pattern for hundreds of hours, and your nervous system literally encodes it. The glutes become inhibited. The hip flexors adaptively shorten. The lumbar spine compensates, and that compensation manifests as the chronic lower back pain, hip stiffness, and knee discomfort that so many of my patients describe despite telling me they walk every day. The solution here is straightforward. Walk outside on varied terrain with your arms swinging naturally. If weather is prohibitive, you may use the treadmill, but release the handrails and reduce your speed or incline to whatever level allows you to maintain proper posture and stride. 8,000 to 10,000 steps daily, primarily outdoors, is genuinely one of the most well-supported longevity interventions in the literature. For added benefit, consider weighted walking, a vest or loaded pack of 10 to 20 pounds, which builds bone density, recruits the posterior chain, and provides metabolic benefit without joint impact. Exercise 3 to reconsider heavy barbell back squats. The back squat has been called the king of exercises. In your 20s, under appropriate supervision, that title has merit. After 40, the risk-to-benefit ratio shifts considerably, and I want to explain why from a structural standpoint. A loaded barbell squat places the bar directly across your cervical thoracic junction, your upper spine, with hundreds of pounds of load stacked vertically. You then flex forward repeatedly under that load. Research measuring compressive forces on the lumbar spine during heavy back squats has documented loads approaching 1,400 to 1,500 pounds per repetition at the L4, L5, and L5 S1 discs, 3/4 of a ton of compressive force through your lower back per rep. In your 20s, intervertebral discs are well hydrated and resilient. They are genuinely capable of tolerating that load. By your 40s and 50s, disc water content has decreased by an estimated 15 to 25%. Discs are flatter, less compressible, less capable of distributing load uniformly. Simultaneously, articular cartilage in the knees has thinned, bone density may be declining, and the protective musculature around the spine is often less robust than it once was. The clinical consequence of repeated heavy spinal compression on degenerated discs is well established: annular tears, disc herniation, nerve root compression, radiculopathy. And as many of my patients have experienced firsthand, the inciting event is often not the heavy lift itself. The disc was compromised during training, and the herniation announced itself when they bent over to pick something up the following morning. I want to be clear. Squatting as a movement pattern is fundamental and should absolutely be maintained. The modification is to the loading mechanism. Goblet squats, holding a single kettlebell or dumbbell at your chest, distribute load very differently and are genuinely effective for lower body strength. Bulgarian split squats, trap bar deadlifts, and leg press all develop the same musculature with substantially reduced spinal compression. You can build serious functional strength without ever placing a barbell on your spine again. A moment of acknowledgement. If you've recognized yourself in any of these exercises, I want you to hear this clearly. You have not been failing. You have been following advice that was not calibrated to your current physiology. The pain in your knees, the tightness in your back, the fatigue that outlasts your workouts, that is not a personal weakness. That is a program physiology mismatch. Now you have better information. Exercise 4 to reconsider: sit-ups and spinal flexion exercises. This is the one that surprises most of my patients because the sit-up has been a fitness staple across military, athletic, and general wellness contexts for generations. The science has moved significantly on this. Dr. Stuart McGill, a spine biomechanist who spent 30 years directing the Spine Biomechanics Laboratory at the University of Waterloo, has produced some of the most rigorous research on lumbar disc mechanics available. His work, conducted in part on cadaveric spinal segments, demonstrated that repeated spinal flexion under load, which is precisely what a sit-up or crunch involves, is one of the primary mechanical mechanisms of disc herniation. After several thousand cycles of forward bending, intervertebral discs begin to delaminate. The nucleus pulposus, the gel-like core of the disc, migraine migrates posteriorly toward nerve roots. This is herniation. This is the injury that produces the radiating leg pain, the sciatica, the disc surgery. The U.S. Army removed sit-ups from their fitness testing protocol in 2020 after nearly 4 decades, specifically because the injury rate to the lumbar spine was unacceptably high. If military medicine reached that conclusion, I think it warrants serious attention. And the aesthetic rationale, the belief that crunches create visible abdominal definition, in Sigreifri Brauwan Swer and Sephoristi and Surisikri is not supported by evidence. Abdominal visibility is predominantly a function of body composition, which is determined primarily by nutrition and sleep. You can perform thousands of crunches and never reveal abdominal musculature if body fat percentage is not addressed. The appropriate alternative is core training that emphasizes anti-movement, resisting spinal motion rather than creating it. Planks, side planks, dead bugs, bird dogs, pallet presses, and farmer carries all build genuine functional core stability that protects the lumbar spine rather than stressing it. Patients who make this transition consistently report meaningful reductions in chronic lower back pain within weeks. Exercise 5 to reconsider: high-impact plyometric training, burpees, box jumps, jump squats. High-intensity interval training built around plyometric movements is enormously popular, and I understand the appeal. You sweat heavily, your heart rate climbs, your fitness tracker reports impressive calorie figures. You feel, in the most visceral sense, like you've worked hard. After 40, however, this style of training carries compounding costs that I see regularly in clinical practice. First, joint loading. Box jumps produce landing forces of 6 to 8 times body weight through the knees and ankles on every repetition. The tendons, ligaments, and cartilage in those joints are not the same tissue they were at 25. Their capacity for load and recovery has measurably changed. Box jump injuries, particularly Achilles tendon ruptures and patellar tendon injuries, occur disproportionately in adults over 40 and almost universally under conditions of fatigue. Second, neuroendocrine consequences. Extended high-intensity sessions produce prolonged cortisol elevation. I described the cascade earlier: visceral fat deposition, testosterone suppression, sleep disruption, sustained systemic inflammation. After 40, your hormonal milieu is already shifting. Adding chronic cortisol overload amplifies every negative component of that shift. Third, and this is the one I consider most consequential, the recovery burden of this training style often crowds out strength training entirely. Patients arrive at appointments exhausted from HIIT sessions, unable to lift weights effectively because their recovery capacity is exhausted. And this matters enormously because we lose approximately 3 to 8% of muscle mass per decade after 30, accelerating after 60. Low muscle mass, sarcopenia, is one of the strongest predictors of all-cause mortality in the literature. Grip strength alone, as a proxy for systemic muscle mass, is in some studies a better predictor of longevity than blood pressure. If your exercise program leaves you too depleted to maintain muscle, you are trading your long-term functional capacity for short-term perceived effort. The evidence-based alternative is two-part and elegantly simple. Resistance training 2 to 3 times per week, 30 minutes per session, at moderate intensity with 6 to 12 repetitions per set, using compound movements: push, pull, hinge, squat. Push-ups, bench press, rows, lunges, hip hinges, planks. Build and preserve muscle. Second, zone 2 cardio 2 to 3 times per week. Walker, Anbury, C, Hander, Anderpan, Anbury, Dand, and Free, and walking, cycling, swimming at a pace where you can hold a conversation comfortably. That combination of strength and easy aerobic work with adequate recovery, exeker alpha kramber cow so amber and sulker crow and sovereignty is consistent with the activity patterns of the longest lived populations studied worldwide. It is not complicated, but it requires letting go of the belief that suffering during exercise is the measure of its value. Your body after 40 is not a diminished version of your younger self. It is a different physiological system with different requirements, different vulnerabilities, and genuinely different optimal inputs. When you train accordingly, the results are real in strength and energy and pain reduction and longevity. When you don't, the costs accumulate quietly until they are no longer quiet. If even one of these points has shifted how you think about your current routine, I'd encourage you to share this with someone else over 40 who may be working hard in all the wrong ways. And keep asking for the evidence. You deserve to make decisions about your body based on what the science actually says, not what the fitness industry found profitable to tell you.